My name is Dr. Neetu Abad, and I'm a behavioral scientist and team lead of the Demand for Immunization team in the Global Immunization Division at the U.S. Centers for Disease Control and Prevention in Atlanta, Georgia. As a social psychologist, one of my biggest passions in global health is integrating social science and behavioral health into public health program research and policy. For my leadership project, I interviewed public health leaders to find out what their ideas are on how to successfully and effectively integrate social behavioral science, or SBC, into public health. One of my interviewees, a senior leader recently retired from CDC, offered a powerful analogy on how to think about behavioral aspects of public health. She views scientific progress as a three-legged stool in which you need to have interventions that work, resources to scale up these interventions, and individual and community willingness to receive and participate in these interventions. The idea is that public health cannot be strong without three equally strong legs holding it up. We focus a lot on interventions that work and are effective, and we can unlock resources to scale up when necessary. But a lesser emphasized area is to ensure that communities want to receive the interventions that we champion. But this is a problem. Why? Because low community engagement is a risk to public health. If individuals and communities do not want public health interventions, this reduces the potential impact of these interventions. We have several recent examples of how behavioral factors influence disease transmission during emergencies. During the Ebola outbreak in West Africa, we saw that cultural traditions around burial conflicted with health guidance to avoid coming into contact with bodily fluids infected with Ebola virus. We also saw that misinformation led people to consume false treatments, such as ingesting salt water or using ivermectin during the COVID-19 pandemic. The recent COVID-19 pandemic demonstrated on a global level how low public trust in health systems can fuel refusals of safe and effective interventions like vaccines. So what do we do about this? Well, my interviews and conversations focused on the role of SBC. SBC is the multidisciplinary study of human behavior and behavioral health, and it encompasses disciplines like psychology, sociology, anthropology, behavioral economics, or behavioral epidemiology. SBC uses qualitative and quantitative methods to understand and address social, behavioral, and cultural factors that influence the transmission of illness and the promotion of health. The following is a list of strategies that were recommended by the leaders that I interviewed. Some of these strategies have been implemented in some sectors, but not all, and not all consistently. We can use participatory SBC research tools that emphasize collaboration and feedback from the community, like human-centered design, to understand how health systems can better serve communities and increase public trust. We can generate evidence of impact. So what do we gain and what risk is mitigated if we integrate SBC interventions into public health? We can advocate for SBC's role in diagnosing and intervening on public health challenges by focusing on outcomes of mutual interest when we're working with different stakeholders, some of whom might not be familiar with SBC. Importantly, we need to integrate SBC into curricula at medical schools and schools of public health so that the next generation of public health leaders are familiar with the principles of SBC. We should cultivate a strong SBC workforce in government, in the for-profit sectors, in the NGO sectors, so that we can work together in public health to address social and cultural factors affecting disease transmission. As a woman and a behavioral scientist, the journey I have been on through WomenLift has solidified my passion to better integrate SBC to improve community engagement and public health outcomes, as well as increase gender equity. My leadership project enabled me to connect with and learn from public health leaders. And most excitingly, I look forward to my next position to lead behavioral health strategy and coordination across CDC, which I will start when I return from maternity leave. I look forward to helping public health become as sturdy as this three-legged stool by focusing on the role of SBC in preventing illness and promoting health. Thank you to the leaders who made themselves available to me for this project. And thank you so much to all of my WomenLift colleagues and friends, as well as the staff, who all have become treasured friends. This has been an incredible journey, and I can't wait to put into practice all that I have learned.